So let's talk about some respiratory problems. Blockage of the airway, that immediate threat to a patient's life, is a true emergency. That kind of goes without saying. So, uh, an airway obstruction or a blockage of the airway. An upper airway obstruction may be defined as an interference with air movement through the upper airway. Plain and simple, it's something that's blocking the way. An airway obstruction may be either partial or complete. A partial obstruction either allows adequate or poor air exchange. Patients with adequate air exchange can cough effectively. They may continuously cough because the obstruction may not be fully relieved. However, they can cough, they can pull in air. Those with poor air exchange cannot. There's also, are they able to speak? Are they able to ask for help? Those are different things too that may interfere or that may help you with a complete versus a partial obstruction. Those with a poor air exchange or a complete obstruction often emit a high-pitched noise while inhaling, or stridorous, stridulous noise, and their skin may have a bluish appearance. They might, depending on how far this has gone, they might be starting to get cyanotic. They might be circumoral, circumnasal, circumorbital around the eyes, uh, potentially in the nail beds, although that's not very uh, telling. I would strict mainly with your other assessment, but in children that is very possible. Um, they also may have increased difficulty in breathing. They would most certainly have an increased difficulty in breathing if they can't move air. They're going to struggle. You're going to see this, which can manifest as choking, gagging, dyspnea, dysphonia, or unable to speak, or difficulty speaking. When you cannot feel or hear airflow from the nose and mouth, or when the patient cannot speak, aphonia, breathe or cough, their airway is completely obstructed. They will quickly become unconscious and die if you do not relieve the obstruction. We need to figure out what's causing that and fix it. In the absence of breathing, difficulty ventilation, the patient will indicate a complete airway obstruction. So, this before, as we discussed in the very first part of this, um, you can't assess breathing if you can't ventilate, and you can't assess ventilation if you can't assess breathing. So this kind of goes right into that. If you cannot ventilate or you cannot breathe for the patient, then you cannot assess the airway patency because you don't know. It's uh, you can't move, so you can't listen. You can't move air, so you can't listen and assess for compliance with the bagging, or listen for air exchange in the lungs or air movement within the lungs. Therefore, you have to fix that problem to make that work. All right, some of our causes of airway obstruction include the tongue, uh, foreign bodies, teeth, spasm or edema, vomitus, and blood can all obstruct the upper airway. The tongue is the most common cause of airway obstruction. Normally, the submandibular muscles directly support the tongue and indirectly support the epiglottis. However, without significant or sufficient muscle tone, as in they are unconscious, and muscle tone relaxes, the relaxed tongue falls back against the posterior pharynx, thus occluding the airway. I believe this is what people think of when they say they have swallowed their tongue. They relax, the tongue falls back, they can't breathe. Or they have the snoring respirations. Some air is moving somehow around it. This may produce snoring respiratory noises. At the same time, the epiglottis also may block the airway at the larynx. This at least diminishes airflow into the respiratory system, and the patient's breathing efforts may inadvertently suck the base of his tongue into an obstructing position. So, if the tongue is relaxed enough, they may pull the tongue back, and that will stop any air from moving any further. Um, the patient's tongue can also block their airway, whether they are lateral, supine, or prone. However, the blockage depends on the position of the patient's head and jaw. So, simple airway maneuvers such as a jaw thrust can usually open this and relieve the airway obstruction from the tongue. Foreign bodies, largely poorly chewed food, can obstruct the upper airway by becoming lodged in the hypopharynx. These causes have been involved in alcohol consumption and denture dislodgement. Um, because most frequently occur in restaurants that are mistaken for heart attacks, they are commonly called cafe coronaries. The patient may clutch their neck between the thumb and fingers, universal distress sign for choking. Children, especially toddlers, often aspirate foreign objects as they have the tendency to put objects into their mouths. Another thing that toddlers tend to do is they will overfill their mouth. If you're not paying attention, mashed potatoes are a great obstructing uh, material. Macaroni and cheese, those kinds of things that something they really like and they can shovel in themselves, they tend to do that. So these are some of the things to kind of look at. Um, trauma, particularly when the patient is unresponsive, loose teeth, facial bone fractures, and a bulged or swollen tissue may obstruct the airway. Secretions such as blood, saliva, and vomitus also compromise the airway and risk aspiration. Additionally, penetrating or blunt trauma may obstruct the airway by fracturing or displacing the larynx, allowing the vocal cords to collapse into the tracheal lumen or into the channel of the trachea. The laryngeal spasm and edema, because the glottis is the narrowest part of the adult's airway, the edema or swelling or a spasm closure of the vocal cords is potentially lethal. Even moderate edema can severely obstruct airflow and cause asphyxia. Asphyxia is the inability to move air into and out of the respiratory system. Just because the mucous membrane that covers the vocal cords is a layer of loose tissue where blood and other fluids can accumulate, this tissue may swell following injury, and swelling may be slow to subside. Causes of laryngeal spasm and edema include trauma, anaphylaxis, epiglottitis, and inhalation of superheated air, smoke, or toxic substances. So something to be very careful of and very cognizant of in a fire or a industrial accident or a spill type situation or hazardous materials situation when responding with fire department. The most common cause of spasm is an overly aggressive intubation. We want to be smooth. You want to take slow, purposeful, smooth movements during intubation. In addition, it often occurs immediately after extubation, especially when the patient is semi-conscious. Some authors propose that laryngeal spasms can sometimes be partially overcome by strengthening ventilatory effort, the forceful upward pull of the jaw, or the use of muscle relaxants, although the success of these maneuvers is variable. It depends on the patient. A lot of times it's just time, and you just prepare. You have your bag, and you continue to attempt to breathe. If it is a laryngeal spasm, and you attempt to breathe for them as you can. If you are fortunate enough to have RSI protocols, which we'll discuss later, you can put in a paralytic and hope that that breaks the spasm. If not, be prepared with basic airway maneuvers until that time. Now, moving on, go to aspiration. Vomitus is the most commonly aspirated material. Patients at most risk for those who are obtunded or drowsy or alcohol intoxication. Anything that depresses the central nervous system and makes you drowsy. They cannot adequately protect their own airways. This can occur with hypoxia, central nervous system toxins, brain injury, among other causes such as mentioned before, depressant drugs and alcohol. In addition to obstructing the airway, aspiration's other effects on the lungs also significantly increase patient mortality. Vomit is exactly what it is. It's vomit. It's food, partially digested food, protein dissolving enzymes, and hydrochloric acid and gastrointestinal bacteria that have been regurgitated from the stomach into the hypopharynx and oropharynx. If this enters the lungs, it can result in increased interstitial fluid and pulmonary edema. The consequence the consequent marked increase in alveolar and capillary distance seriously impairs gas exchange, thus causing hypoxemia and hypercarbia. Aspirated materials can also severely damage the delicate bronchial tissue and alveoli. Gastrointestinal bacteria can produce overwhelming infections, and these complications occur in 50 to 80% of patients who aspirate foreign matter. You know, think about it, it's acid. Where not only is it the bacteria and the partially digested food, but it's the hydrochloric acid. And what is that going to do to these thin, delicate tissues? It's going to severely damage them. It's going to take away their elasticity if it even allows them to remain intact. Insufficient minute volume respirations can also compromise adequate oxygen intake and carbon dioxide removal. Additionally, oxygenation may be insufficient when conditions increase metabolic oxygen demand or decrease available oxygen. A reduction in either the rate or the volume of inhalation leads to a reduction in minute volume. In some cases, the respiratory rate may be rapid but shallow, that little air exchange takes place. Among the causes of such decreased ventilation are depressed respiratory function, as from impairment of respiratory muscles or nervous system, bronchospasm from intrinsic disease, fractured ribs, pneumothorax, hemothorax, drug overdose, renal failure, spinal or brainstem injury, or head injury. In some conditions, such as sepsis, the body's metabolic demand for oxygen can exceed the patient's ability to supply it. Additionally, the environment may contain a decreased amount of oxygen, such as high altitude conditions or a house fire, which also produces toxic gases such as cyanide and carbon monoxide. These situations of inadequate ventilation can lead to hypercarbia and hypoxia. So, multiple things going on to run with inadequate ventilation. You've got the body fighting against itself and metabolic stuff, metabolic things as well. So these are things that we need to do and try to mitigate. If they're in a smoky room, we get them out. If they are increased respiratory rate with a shallow depth, we can either high flow oxygen, or to make up for the oxygen that they're not getting and hope that they slow down and hope that fixes the problem. And if that doesn't work, we can elevate up to positive pressure ventilations to help force more air in, depending on what the problem is. Again, it's all about our assessment and what we find out what's going on with the respiratory system, not only with the system itself, but also with the structures.